And good evening, everyone. Dr. Bill Tullo, Medical Director at Oculus, and welcome to the Oculus Clinical Webinar Series. Tonight, I am really excited to welcome two of the most prolific contact lens fitters in the world, Dr. Ken Maller and Dr. Chris Sindt. Before I do formal introductions, just some housekeeping. If you have questions tonight, please put them into the chat so that we can compile them, and we'll leave some time at the end of the webinar to answer your questions. If we have too many questions and we run long, we will certainly answer them remotely via email. Again, tonight is really an exciting talk. It's called Data-Driven Designs to Avoid Problems to Ultimately Create a Better Lens. Chris, I'll introduce you first. Dr. Chris Sindt graduated the Ohio State University College of Optometry in 1994. She completed her residency at the Cleveland VA Medical Center in 1995. Dr. Sindt joined the faculty of the University of Iowa Department of Ophthalmology and Vision Sciences, where she's currently professor of clinical ophthalmology and director of contact lens service. She also serves as a consultant optometrist for the Ohio City Department of Veterans Affairs Medical Center. Dr. Sindt is chief clinical editor for Review of Optometry and serves as a peer reviewer for several journals of ophthalmology. Dr. Sindt holds 7 U.S. patents and over 150 publications. She's the inventor and founder of EyePrint Prosthetics and obtained FDA approval for her process and design, and her designs are now in global markets. Dr. Ken Maller earned his doctorate from the Illinois College of Optometry and is currently in solo private practice in Fort Lauderdale, Florida. His practice is devoted to orthokeratology, myopia management, as well as providing visual rehabilitation to the irregular cornea. He's one of the foremost wave contact lens designers in the world and authored the first wave contact lens designer certification program. Dr. Maller lectures extensively on custom contact lens design as well as providing clinical consultation services. Dr. Maller also is one of the first doctors to start using the Pentacam corneal scleral profiler scan, or CSP software, including when he was still in beta over 5 years ago. He's a fellow in the American Academy of Optometry, a diplomate of the Cornea Contact Lens and Refractive Technology section of the American Academy of Optometry, and a fellow in the International Academy of Orthokeratology, and a diplomate in the American Board of Optometry, and a fellow of the Scleral Lens Society. Wow. And I'm sure we shortened that down. It's amazing the credentials of these two speakers tonight. So with no further ado, I'm going to hand it over to our speakers tonight. Guys, take it away.
Well, thanks a lot, Bill.
Thank you.
And welcome to Chris, and I'm very happy to be here as well and sharing the stage to present this wonderful material that we're going to be doing tonight. So we're going to be talking about data-driven designs to really create much better lenses and to get to those results more expeditiously, as well as ultimately provide a much finer outcome at the end. You could see there we've created a little crystal ball there with the diagnostic contact lens fitting and the tombstone, because I really do believe that that is not the future. The future really is getting all of this data so that we can really design some phenomenal plastic that can really do a job much, much better than we can do through the diagnostic fitting process. And let's go ahead and start advancing some slides. This is a little bit of who we are, although Dr. Tullo has certainly gone through all of our credentials and the like there. So we're just going to kind of move along here. All right, so the reason that we really want to design these is so you can really give your thought process to the patient and think about the case and let the data drive the design so that we can get the eye successful. And I just prepared this brief slide here, sort of comparing diagnostic fitting to data-driven fitting. And you can see here on the benefit side, diagnostic fitting really has only one benefit. And the benefit is that you don't actually need a scleral profilometer to do the process. You can do this all by grabbing a trial lens set, assessing things at the biomicroscope, and then making appropriate changes to whatever design you happen to be working with. If you do have a profilometer, it actually does help that process, but it is not mandatory. And so that's a limited investment that you would have to make to start doing these types of lenses. However, on the disadvantage side, you see there's a lot of disadvantages to diagnostic fitting. It's more chair time. The patient experience is not very pleasant. The inventory of lenses have to be maintained, and you have to be able to disinfect them properly as well as refile them, and so they're good to go for the next patient that you're going to be taking care of. The parameters themselves are somewhat limited by whatever the designs are being offered by that particular laboratory within that particular framework of design. And making very specific focal changes is either very difficult or actually impossible to do. Whereas if you're doing the empirical fitting, from the data, you don't need any lens inventory. It is very quick and efficient to get to success. You really can get very unique design features into the lenses to solve very specific requirements of these eyes, and again, change these very, very unique spots that may be problematic, and you absolutely will improve your success rates. The only disadvantage is that you do need to get the equipment so that you can collect the data. And when you're both learning how to utilize that particular equipment as well as designing from the software side, that does require a little bit of investment in time so that you can learn what to do, because now it's really all up to you, because it's not coming from a fitting guide that has been run through R&D and put out into clinical service to give you an idea where to go. I'm going to let Chris take care of this one.
Great. So when I started fitting scleral lenses in the late 1990s, it really fit into the category of we didn't know what we didn't know. And we just started putting lenses on eyes, and if they stayed on, that was great. And if they made the eye red, yeah, whatever are better options, right? But with data-driven designs, we really start to know. We start to, beyond just K ratings and diameter, you get these elevation differences. You know what the depth of the cornea really is, and how the eye changes. And that allows you to really start thinking, how am I going to fit this lens, and how am I going to solve these problems? Because eyes really aren't just round or not round, right? They're incredibly complicated. And so we know more than we did before. Go ahead.
So here we have three types of profilometry that are available over here that we're discussing. On the far left there, you see the eaglet, ESP, that's the eye surface profiler, giving you a colorful map and a cross-sectional view of the elevations there. In the middle there, you see the Pentacam corneal scleral profiling system, and that's all of the arcs of all the various cross sections that have been captured. And then on the right-hand side is the eye impression data that's done through EyePrintPro, or it's affectionately known as the blue goo, so that we can get a real good impression of what's exactly on that eye. So how the workflow proceeds when you're doing these, you'll see I labeled there step number 1 on the left-hand side, and basically you collect data from something, whether in this case it's the eye surface profiler or the Pentacam that's in the middle, or the impression data. And then you get to step number 2, and this is very important. You have to assess how good is the quality of that data that you've gone ahead and collected. If the data is no good, trust me, you will not get a lens that's going to work. It doesn't work that way. You do have to really understand the equipment. You have to be able to get good impression, or you have to get a good capture with the profilers, so that you do have good quality data. That's then fed into software. On the top half of the screen over number 3 there, that's the Wave software platform, which I've been utilizing now for just about a quarter of a century. And down below is the EyePrintPro software, so that you can manipulate that data and create those lenses. Number 4 is really the sum total of what did we just achieve, and you are going to get a very unique lens that's manufactured and then evaluated on that particular patient. often, if you've done a really good job at collecting the data, the first lens is going to fit anything between excellent to perfect. Because if you have the data, you will design a lens that fits properly. Usually it only requires very minor adjustments, and most often it's primarily just an optical adjustment that you have to take into account, because especially if you're dealing with irregular eyes, it's very difficult to get good optical data to know what needs to be into the lens.
Mhm.
As you get
You,
better, oh, go ahead, Chris.
Yeah. One of the things that changed my thinking, Ken, when I went to data-driven designs, is rather than thinking like, oh, how do I change that curve? Do I need to steepen the curve or flatten the curve? I started really thinking about the eyeball. And when I put a lens on the lens that you dispensed onto the eye, I think, do I need it closer to the patient or farther away from the patient? So you start thinking this way on the eye as opposed to curvatures. And I find it's a much easier concept, oh, I need that spot to be off the eye a little bit, or I need that area to be closer to the eye. And you can change those in the software like you're showing so much easier than trying to decide, well, if I change this curve here, is that going to shift the whole lens in a different direction?
You're absolutely right, because I have a drawer full of diagnostic sets that have a 3-inch layer of dust on them because they've been sitting there for the last 20 years or so. Because I, like you, have been using these data-driven designs for that long. And it's a very, very strange concept for me when people will come up to me and say, well, did you steepen the base curve? Or did you steepen
And you're like,
this curve? I don't think in terms of curves. I think in terms of how much clearance is there between the plastic and the surface of the eye. That's how I think. I think in those,
right.
exactly as you're saying, does it need to be closer or does it need to be further away? And you really
Hmm.
do move away from that whole idea of curvature at that point. So
Yeah.
you're 100% right.
Yeah, and part of the workflow that people really need to think about in their clinic is when you're using a diagnostic fitting set, you have to let that lens settle onto the eye. You can't assess a diagnostic fitting lens in the first, say, 30 minutes. You need to put it on, let it settle down, and then decide how that fits and how you're going to change the curve from there. That is a huge chunk of chair time, and that is very expensive. You think, oh, this lens, this diagnostic seems less expensive. You start adding up those 30-minute chunks of your time, it's very expensive. The other thing is you put a diagnostic lens on the eye. If it doesn't fit right, you've now irritated the eye and you have to abandon the fit for that day. It's like trying on shoes when your foot is swollen at that point. You can't keep going with that fit, right? Because you're going to pay for it. You're going to have another visit and another visit and another visit and another visit.
Well, let's
Chair
not
times are
forget.
really expensive.
Well, let's not forget. We not only irritated the eye, we irritated the patient as well, and
And your
that
tax and the
costs.
doctor.
Right, that costs too. When the patient is getting
Uh-huh.
irritated, that's really problematic as well. So it really is. It's a wonderful thing to be able to get that very first lens on and have it so close to perfect. It really makes the entire experience for the doctor and the patient much, much more pleasant. So, and you're
Right.
absolutely right about that. Okay. So why don't you talk about this picture?
Sure. So data-driven designs give you control points over the entire lens. So not only can you just say, you don't change the base curve, right? You change the clearances. Well, how much space do I want underneath that central part of the lens? Okay. In the center, in the mid-periphery, you can raise or lower that point. That mid-peripheral control there, independent of of the center of the lens, that mid-peripheral control is where when you get fogging, you're getting fogging because you are over vaulted. So in this example here, we see the eye. We see where that lens is sitting on the eye. You have to be able to manipulate that lens so that you don't have that over vaulting area, because that's where you're going to start pulling stuff in underneath the lens. That's in an area where you have suction. You're going to get that midday fogging. So you want to be able to control that area separate from the rest of the lens. Go ahead and click again.
Absolutely.
So by doing this in 3D space, you already know where your problems are. We hear a lot in these Facebook groups and, online or when we read articles about that limbus. And people will say, protect the limbus, don't crush the limbus, right? Well, you will never crush the limbus in a data-driven design, because these data-driven designs know where the limbus is, right? So you create that lens so that you're not going to squish the limbus. But here's the thing, overvaulting the limbus is really just as bad as undervaulting and squishing the limbus, right? You don't want to rub those stem cells, but you don't want to create so much vault over it that you literally suck it up to the back, suck your limbus back to the back of the lens, because that's going to cause that smile that you sometimes see when you put on a lens, and in that bottom you get that red ring. That's overvaulting the limbus in those cases. You really do want to avoid that, because that is very irritating to the patient. So you want that alignment. You don't want it to dig in. You don't want it to overvault. You want that alignment to there. It's okay if it looks like it's touching. You don't want it squishing.
Correct.
Go ahead to the next area. Right? And then you want to be able, you can move these designs around, right? So that it's centered, so you can get your optics centered over the eye, instead of just having it decentered down and inducing coma and other aberrations to the system. Right? So when you have decentered optics, your patient can say, my vision's worse with this lens on than without it on. Right? You want to make sure you can move those optics and get this optic centered. Okay?
That's correct.
Now, yeah, we brought it up when we said about the limbus, right? You don't want to squish the limbus. Well, a lot of these lenses out there, diagnostic fitting, you actually have a round lens that you're trying to put onto the eye. But when you actually know where the limbus is, you design the lens around those limbal points. And the limbus is not round. The limbus is also not what we always, diameter-wise, what we always historically have said, right? We always said it's like somewhere between 11.5 and 12 millimeters. But that's the visual limbus. The geometric limbus, where you're actually having that shape change, is bigger than the visual limbus. And when you're fitting a lens, that's a geometry issue, and you need to fit the geometric limbus. The visual limbus is usually about 0.5 millimeter smaller. Yeah, and the limbus is actually, not only is it not round, it's not planar. Right? The limbus is actually like a hyperbolic paraboloid. It's like a Pringle potato chip. So at 3 and 9 o'clock, it's going to be higher up. At 6 and 12 o'clock, it's going to be lower. So it's going to go up and down and around like a Pringle, like the rim of a Pringle potato chip.
Absolutely.
With these data-driven designs, you can also say, gosh, you know what, I got that pinguicula. A pinguicula, which often I can guarantee you didn't even notice. How many times does that happen, Ken, where you get a lens on an eye and then, when you did diagnostic fitting and then you thought, oh, that's pinching in that area and that's going to be a problem, right? I didn't really notice pinguiculas till I started making them really mad. And I've made pinguiculas mad before. But with data-driven designs, you know where they are, and you can create these little focal points, right? You're not guessing. You're not saying like, oh, yeah, I don't know, maybe that's 500 microns, 200 microns, 100 microns. I mean, do you even know how big a micron is, right? But with data-driven designs, you know exactly where it is. You can create that extra clearance over it, or it automatically happens for you. You don't even have to think about it. It just happens for you.
Right. You know the elevations of these things because it was captured right there at the beginning in the capture system, whether it was through the, like I said, the eGlit or the Pentacam, or even in the impression.
Yeah, and so the software says, I see a bump there, and I'm just going to align with that bump and create
That's
that bump.
correct.
So to use profilometry data, this is kind of what you were getting at before, right? You minimize the chair time by either selecting the first lens out of your diagnostic set, right? So say you don't want to use software, right? At least the data-driven design can say, choose this one first, right, to put on, or it can go as what we are talking about, and I think, Ken, what you and I prefer to do is do these empirically driven designs, right, and have it be, first fit. And most of the time you can actually dispense, even on the most complicated of eyes, you can dispense that first lens at least, even if you have to make a little power change.
You're absolutely right. That first lens dispense really does go up rather high when you start designing this way using the software.
Okay.
Okay.
Yeah, chair time is expensive. All right.
Yes,
So this
is
here. Yeah, this particular patient, he presented to the practice wearing his habitual lens. And his complaint was his eye always hurts, he's red. People think that he has been drinking or that he's unwell or unhealthy. And he presents with this you can really see this pinguicula here with some impingement right at the limbus. And, if you were to look at this, you'd think maybe that lens is a little too small for that cornea, that might be a little bit on the small side for that particular design because there is so much impingement there. So we ended up, go ahead and click again, we ended up taking him out of this lens and we washed him out. Do not fit an eye that is that red or impinged, because that is a lot of inflammation and you do want to calm that eye down before you gather your empiric data. Otherwise, it's like, again, trying on shoes when your foot is swollen. You're not going to get quite the right data. So you do want to calm that eye down. So we washed him out. We added a steroid to calm him down pretty quickly, and then we brought him back. I usually suggest that people stay out at least 48 hours. Now, the hotter the eye is, perhaps the longer you need to keep that person out of the lens. Certain lens designs, super tight fit lens designs, you need to keep him out a little bit longer. But we washed him out, and you can see that little pinguicula is a little yellow now, right? It doesn't look quite so irritated or annoyed. But go ahead and click again. Right. What you may not notice is on the other side of the eye, there's also an elevation. So he really has 3 9 pinguiculas. It's just that one is so prominent, we tend to zoom in and look at that. But he's got one at 3 o'clock too, on that nasal side. But what you didn't notice is he's got an elevation right at that superior limbus. It is very hard to see. Sometimes these elevations and these spots are very difficult to notice on patients' eyes. We zoom into what's the most obvious thing.
No, I didn't know about this case, but what I had noticed on the previous slide when the pinguicula was very angry, and you had commented about the fact that the lens looked a little small, it also looked like it was inferiorly decentered. And I would be willing to bet that elevation on the top is pushing that lens down.
Yeah, the whole thing has kind of moved its way down. Yeah.
Down.
These subtle things, they change the fit, right? Now, here's what's really interesting. When we did profilometry on this patient, it picked up those 3 and 9 elevations, but it also picked up that superior elevation there as well, which you did not notice. I did not notice when I just looked at the patient. Okay. Now, what I want to point out here is on this particular patient, and just for this particular lecture, I did the elevation scan, but I also did an impression just so that we can compare. Now, in my world, I do a lot of validation, right? So I'm always validating different modalities, different ways to make sure that software is behaving the same way. But I want you to notice on the impression here, you can see that superior elevation on that impression, and it got picked up on both of them, and you can see the pinguiculas there as well. What I do want you to notice down at the bottom, I put the major and the minor limbal shapes. What I want you to notice on this picture is that they're very similar. But it is the limbus is very oval or hyperbolic paraboloid in shape, right? And that's another reason that lens was dropping, was when you put a round lens on something that's not round, it tends to kind of fall or anchor at those 3 and 9 points and just kind of fall down off the eye. Sure. Go ahead and click again. Every point matters, right? And so when you have an eye like this, you can go in and say we know that pinguicula tends to get mad. You can go in and actually elevate the data in that particular area. Maybe give it a little bit more clearance, a little bit more grace over something. We all know that pinguiculas kind of go up and down a little bit over time, depending on how dry the eye is. So you may want to go in and just give it a little more grace, especially if it's an eye you know well.
Sure, and you can see the very nice oval shape delineated by
by the line,
blue oval
yeah.
there, yeah.
My blue oval, my limbal shape. Yep. And you can see it. Here's the design here. You can see how that pinguicula has a very subtle, but it goes up and over that eye, or that pinguicula there. Go ahead and click again. Right? So it's not for the most dramatic. We see pictures on Facebook of all these super wavy, complicated eyes. Those we know they're complicated, right? We know they're complicated. We go into them. Sure. It's an eye like this that you don't want to be complicated. You want this person to be a regular Joe Schmo. He comes in and you fit him and he leaves and you collect the money and you all move on in your life and everybody is happy with the relationship. Here you can see those data-driven designs and just how happy that eye looks after he's been wearing that contact lens. So, you recognize problems before you fit. You can create these asymmetric designs, and then you can focally modulate the lens if you need to create more area.
Fantastic job there, and you just hit
Hmm.
on something that I'm very quick to point out. My menu is short. My agenda menu is short. I want the patient to come in. I want them in and out of my chair as fast as possible, and go tell the world I'm the best in the world. Send your
Hmm.
friends in. That's basically it. And you really don't want to waste chair time. You're 100% correct on that.
And I want to spend my
Okay,
chair time getting to know the person. I want to
there
know
you
who
go.
they are. I want to
And
know what makes them tick. I don't
well,
need to spend the time thinking about plastic. Yeah.
that's correct. And the more you know about them, the better job you can actually do addressing their specific needs. So,
Right.
okay, this one looks like mine. So
Yeah.
here on the Pentacam CSP screen over here, what we could see on the left-hand half of the screen are the cross-sectional arcs of this particular eye. And on the right-hand side of the screen, you get a whole bunch of data. You could see that the scleral angles are being given at a specific chord along those principal meridians, along with also the sagittal depths over there. Uh, in the middle there, you can see that there's a graphic referring to how much coverage was grabbed during that capture. And then you can use all those sort of unique sagittal depths to create a very patient-specific three-dimensional reference surface so that you can then design a lens around that. And that's basically the process. So if we take a look at the cross-sectional arcs over here, you can see that you get the overall shape along each meridian. On the left-hand side, you see the actual cross-section. You can see number 6, it has a little square around it. That's the vertical meridian over there. And on the right-hand side where the arcs are, that's the one that's in red. So it's corresponding to that red cross-sectional arc, and that actually is the vertical 90-70 degree meridian. You can see the extent of coverage. You can see on the lower right there where I have a perfect circle, that's an elevation. And you can see how those arcs are going up and over that particular elevation on the cornea. And then also on the inferior portion of the cornea where I have that vertical oval on the left-hand side of the arcs, that was dropout. I just wasn't able to capture any data there due to the unusual shape of the eye. Now on the actual numbers that are given, I just blew this up a little so you can see this over here. You can see I selected a chord of 15.8 because I happen to be doing a lens of that diameter. And on the red-blue cross sections that you see there, those are the principal meridians at that particular diameter. And it's giving you those principal ones along with the angle as well as the actual sagittal depth there. This is that coverage map I was talking about, and you could see on the upper left there that yellow-blue picture down at the bottom, the inferior, that was that inferior portion I was having trouble grabbing a hold of. And then, of course, on the color map, that color-coded map on the right there, you could see what the actual elevations are with reference to those spheres. So here's a case. This fellow has keratoconus. I'm not talking about the right eye here because on the right eye I designed up a wave corneal GP multifocal, and he's at 20/20 plus in that eye with J1 at near, so J1 minus at near. So he's doing very well on that eye, but the left eye's keratoconus is a little bit more advanced, and we needed a scleral. And yes, you can mix and match lenses perfectly fine. He's very comfortable in the corneal and the scleral. They're equally comfortable for him. But in this case, I designed a 15/8 scleral lens. It's a freeform wave design, which is in the lower right-hand part of the screen. I did make this a multifocal, and I took a look at the sagittal depth extremes there, and you could see the extremes that were measured are about a 1.5 millimeter difference. 1.5 millimeters on an eye is very, very big. That's a lot of territory to cover with a lens. And if you take a look at the graphic on the upper half of the wave screen, you can see on the inferior portion of this lens, which is on the left-hand side, just how much deeper down that lens goes than it does on the superior portion on the right. With this scleral lens, he's at 20/25 minus and J1 minus at near, which is a phenomenal result on this keratoconic eye. Now, this is a second case I was presenting today, and it's a very interesting case because this was a traveling patient. This patient traveled in to see me from a fair number of miles away, and he's a 41-year-old who was diagnosed with keratoconus, and he's wearing a pair of piggybacks on both eyes, a soft and a corneal GP on both eyes, and he's very comfortable with them. But the vision quality has been decreasing. He's been getting some scarring and striae, and the ophthalmologist where he lives had recommended being refit to a scleral lens. They did that locally, and he was very, very uncomfortable. After a couple of hours of wear, the eyes became very inflamed, and you could see the pictures down there. The right eye is on the left, and the left eye is on the right. That's what his eyes look like from wearing the scleral lens. He was told that he needed his pinguiculars removed, so he went to another doctor to see about removing them, and that doctor said, no, they're not really that bad. Please just go get a better fitting lens. And that was when he had reached out and contacted me to travel and to see me. And so if we take a look here, you could see the arcs, the cross-sectional arcs there, giving you an idea of the shape of his eyes. The right on the left side of the screen and the left eye on the right side of the screen. I captured data out to 18 millimeters. I designed the lens at 15.5 millimeters. You can see again, the sagittal extremes on this lens are pretty high. It's almost at a millimeter on both lenses. And I put the parameters in over there, and you can see the refraction that I had entered in. And these are the actual lens designs that I had designed for him. And his outcome was he's now 20/20 in each eye. He's got full day wear, and he gets no redness whatsoever. So he was really taken care of very, very rapidly, which was very helpful since I didn't have him staying very long. He was actually only going to be in town for about 10 days for me. And so this was from a Monday through to a following Wednesday, at which time he left. So that's a very, very straightforward keratoconus case. And yeah, he was all successful, 1, 2, 3, very, very simple. And yeah, he's doing absolutely fantastic. Now, the interesting thing was that since he had to make the trip, he decided to bring his mother with him. And he was, this is this patient, the 68-year-old, who was just a traveling companion. And she was sitting in the room with him, and I looked over at her and I saw she's wearing glasses. And I said, "Do you have keratoconus too?" And she said, "Oh yes, I have keratoconus, and I had a lot of other things too." And so you can see her glasses that she came in wearing. The right eye is the better seeing eye at 20/80 minus in the pair of glasses. She has no usable vision in the left eye with those glasses. She had bilateral PKs about 20 years prior. She's also had bilateral cataract surgeries with implants, and that was about 7 years ago, 7 and 6 years ago, respectively. But prior to the PK, she was actually doing pretty well, both with hard lenses and gas perms, for about 20 years. So she was really doing very, very nicely. But once she had the transplants, not so much any longer. She had tried to get a lens on both eyes and failed miserably with all the corneal and scleral attempts. The left eye's had no usable vision for the past 20 years, and it's not correctable in glasses. And she did try to get some more sclerals more recently, and it was an awful experience for her. She was traumatized from the experience because it was so painful. So if we take a look, we could see exactly why they were having such a difficult time getting these fit. These are the cross-sectional Scheimpflug images that I captured on her. And you can see the right eye is a very, very proud graft, but the left eye is beyond proud. That's a very, very deep chamber. You could see that the left-hand side, how thin the cornea is at the transition between the donor and host cornea. And that shape is very, very irregular. So here's the right eye, and the corneal scleral capture I had done it with 2 captures at a 15 millimeter cord. She had very, very small apertures, and I was going to really try and get a very small lens on her. Again, considering her age, and she really has never had any scleral lens history, and she's really been traumatized, the last thing I wanted to do was traumatize her further. So the left eye, however, you could see how much trouble I had getting data. There's missing data on the arcs on the left-hand side, and you could see on the upper right-hand side, there is no data whatsoever. That's my first problem. Right there on the coverage map, you could see just how much difficulty I had capturing the data with the Pentacam on this. So since I didn't have any data like that, what I did is I resorted to a little bit of resourcefulness from other screens on the Pentacam so I can get some sense of what's going on. I knew I was going to fit about a 15mm lens. So I went ahead on the left-hand side there, you could see the CSP of this patient through the one cross-section, and I compared that to a normal eye on the right, and you could see the difference in elevation on that left-hand side by that drop. That drop is considerable compared to what the normal drop was on the normal eye. So I went ahead and measured it because that's one of the things you can do just by left clicking on that screen. And you can see there that the sag on the left-hand side there is a little over 6,000, where on the normal eye it's about 4274. We're talking about almost 2mm drop. And so that's a very, very depressed eye, depressed portion of the eye over there at the 15mm chord. So obviously that's my second problem. First one is I'm missing data. And the second one is we're dealing with a 2mm difference in elevation at the sagittal extremes. I also had the retroillumination, and you could see the normal eye on the right, which is nice and bright, and on the left you could see how dark it is, and that was from the scarring on her cornea. She didn't have any cataract any longer. This was purely corneal, and so this is the third problem. We now have a very, very scarred cornea. I'm not going to go into the details of densitometry they can do on the Pentacam here, but what you can see is basically on a normal cornea, that lower left-hand screen is dark, and the darker it is, the better it is, because that means all the light is getting through. On her eye, all those white spots there are basically reflectivity, and the whiter it is, the worse it is, and now we can see why on the retroillumination it was so incredibly dark. This was right at the very, very surface, and then I dropped that down a little bit further into the cornea, and you can see just how reflective the entire cornea is over there. So this was definitely going to be another problem dealing with this left eye. Just for the purpose of this lecture, I put this together here. You could see the top is the actual Scheimpflug image I captured, and on the bottom, what I did was I just rotated that 180 degrees around so you can see just how different the nasal and temporal elevations were going to be on this particular eye. There really is probably close to a 2mm difference. So I went ahead and I used this Scheimpflug image to actually try and measure that. And you could see what I got here is I got about 4395 to about 5000. So this was saying it was maybe about a millimeter. This is not the best way to measure, but at least gave me some sense of where the actual surface of the eye was going to be. Once again, on the left-hand side, you can see just how thin the junction is between the host and donor cornea. These were the actual color maps. We have a lot of extrapolated data there, but even so, you can still see that I circled that box at the bottom. That inferior portion, it really is incredibly depressed from the reference sphere. And so I went ahead and designed up a lens. We're not going to talk about the right lens because the right lens was actually very straightforward for me, but this left lens was very, very interesting to try and get a lens designed on there. And these were the parameters I had on that first lens. And I went ahead and put that lens on her, and we got on the right eye, first lens 2050 minus left eye 2400, but look at where the acuities are with the over-refraction. We had some real good potential for vision there, 2025 plus on the right and 2030 minus on the left. Very nice for an eye that hasn't seen for 20 years. Looking at the actual fit, you can see even despite all of that missing data, I did actually pretty well on both eyes. I had a little bit of inadequate limbal clearance on the left eye. The center was a little bit higher than I wanted, but it wasn't really terrible. And she was leaving later that day. But now she was very excited, and she told me she was going to come back about a month and a half later. So what I did was I went ahead and ordered a pair of lenses for her to be there for her arrival when she came back. So she came back about a month and a half later, and this was the second lens that I had put on her. And on the back surface of Wave, you get all of these color maps so you can actually appreciate what the changes are because they're very hard to see from that screen. But what you can see is on the projected fluorescein map. I did increase the limbal clearance and the edge clearance on both. And you could see I also weighted in the -4 over refraction into that second lens. So how did we do? Well, the right eye was 20/40 plus, the left eye was 20/50 plus, and for some reason she still had some over refraction data. But look at where we are now, 20/20 on the right eye and 20/25 minus on the left eye with a little bit of over refraction. You can see now that the fit is quite nice. Both lenses are actually fitting pretty nicely over those very, very tough eyes. So here in just 2 empirically fit lenses, we already have a very good fitting lens. I trained her up and I had her come back 5 days later so we could see how things were going. In the meantime, I ordered up a third lens to deal with that over refraction because again, we were on a time crunch. So you can see I made no changes on the nasal, temporal sides, superior, inferior. I kept all that the same. Basically, all I did for the left eye is put in the +175 over refraction. When she came in, I want to assess how that second pair did. She was doing very well. Her vision was good. She was very comfortable. She's still having trouble getting them on and off, and they were on for 3 hours that day. She was about 20/30 and 20/50 respectively. The right eye was fitting absolutely perfect. The left eye, it was really good, but I noticed there was some inferior conjunctival prolapse over there, so I probably was a little too gracious on the limbal clearance inferiorly. Removed the lenses, and they came off very easily. She had no staining on the cornea whatsoever. Went ahead, put the third pair on. Right eye's at 20/20 now. Left eye was at 20/30, and strangely enough, she took another +1, which got her to 20/25. She was leaving later that day, and so I let her leave with that pair. Yeah, there was still a little inferior conjunctival prolapse because it was already there from the previous lens I had just taken off. And what I had told her was that since she was leaving, I'm going to design another pair for her for when she comes back. I gave her an RX for some reading glasses to wear over it, and I told her to follow up with the local doctor if she had any problems. I did get a follow-up. She didn't get to make it back to me. She's actually coming back in another few months, but she's done absolutely fantastic with the lenses over the course of the year. So that's a really wonderful case, and there's no possible way you could have done anything like that quickly or as efficiently with any type of diagnostic fitting.
That is a great case, Ken. Oh my gosh, you really couldn't have done that without knowing and some type of data to be able to move that forward. You know, I find it interesting. I think to be honest, I might have stopped at lens number 2 with the over refraction, and I'll tell you why. This is not rehearsed, right? I'll tell you why I would have stopped at lens number 2 is because you had plus in your over refraction, you were actually creating a telescope on her. And so sometimes in these cases, having that little bit of a plus in glasses on top of it is an advantage. And sometimes you get better vision with that plus in the glasses because you are actually literally creating a telescope system for that patient's eye. And especially if they need a bifocal anyways, sometimes I just go ahead and I give them the plus in the glasses with the bifocal because they'll actually see a little bit better with that extra little bit of, now if they're +5, I wouldn't, but a +1, +2, I might leave her at that.
Well, I can tell you, my plan when she comes back is I'll get a multifocal on there as well. So it's just a matter. It's just we had to get the distance taken care of first.
I know where I'm sending all my patients now, Ken.
There you go.
Now, an eye like that is really complex, and that might be where I jump to impression technology for my personal patients. Just because you get those really subtle complexities and you don't have to, my brain, I don't have to jump through the math that you did, but I spend a lot of time trying not to think, actually. So go ahead and click one more.
All right. So let's
so
up here.
So with impression technology, you get a lot of data. So all the areas where you can't get that missing data, you really do get that data when you do impression technology. And so you get that data in straight ahead gaze, under the upper and the lower eyelid. And so there's some really complex changes that patients have out in the far periphery. It's so subtle. I actually had a patient where I took the impression out and I'm like, what is in there? And when I actually had the patient look way down, and I flipped the lid way up there. The patient actually had an ocular tumor that came out in the, or that showed up in the impression, and that's how we actually diagnosed it, was looking at what the elevation differences that were coming out in that impression. So we call this elevation specific technology, and every single point matters. And I'm going to tell you how this kind of software works. But when you create 3D, so you're in the 3D space and you create these STL files, really everything is this mesh. We call it this mesh work, and it's these tiny itty bitty triangles, right? So rather than thinking of curves and raising and lowering things, you have these little intersected triangles, and basically think about it like grabbing one of those intersections where the triangle comes together, and you can pull it up or pull it down, and it creates sort of this, I think it kind of looks like chainmail, right? But on the surface of the ocular surface, it will look like that as well. So you can get these, if you have an undulating eye, you get these complex curvature changes that go across that eye. So we say every single point matters, and the size of these triangles will depend on the complexity that you can cut. So the smaller the triangles, the more complexity that you can cut into that lens, but then the greater the lathing time. So when you start creating lenses that aren't round and really weird things on the eye, it takes a lot longer to cut those lenses. But you can get that focal changes. And however, though, once you really have a lens that fits very securely onto the eye and doesn't move with blinks and things like that, you can start putting these advanced optics on. So, I've been playing with just very high resolution, higher order optics on these lenses. So we now can take, like your patients, we can drill down through all of these crazy, optical situations, and really, like you said, you could not just put multifocals, but we can do HOA corrected multifocals and lots of things on these patients' eyes. Great. So with the EyePrintPro product, this is an impression-based product, and we do things. We can do prism in any direction, the multifocal optics. We can decenter the optics on it. So we can decenter the front and the back optics, right? The back of the lens is for fit, and the front of the lens is for optics. So we can move those optics independently of each other. The higher order optics. We can do elevation specific transition zones. So not quad specific, right? But on the cornea itself, we can come in and we can go over pterygia, for example, that are growing onto the cornea and create that elevation specific design on the cornea itself. And we can, of course, putting in fenestrations. I think that's something that we need to talk more about as we get into some of these really sick, very, very complicated eyes, adding them in for protection. Here's an example of impression technology in creating these not round lenses. But what I want to point out to you here is it also can be done bedside. So the patient doesn't have to come to you, you can come to the patient, right? I go bedside. I frequently will go into the PICU. I can go to nursing homes. Patients can't ambulate out of the chair. They can't get to my high-tech equipment. We can take an impression anywhere, anytime. As you know, Ken, I have taken many impressions in exhibit halls, hotel rooms, hallways, restaurants, parties, bars, wherever you want them. But here's a little one. I did his first impression at 5 days old, and he is 3, maybe almost 4. I don't know. He's an amazing addition to my life, I suppose. And we've done this not round lens, and we've actually saved his eye. And they've actually chosen not to close the coloboma at this point and do lid surgery because he's just doing so well in the contact lens that they're just waiting for the eye to grow and wait for the appropriate tissue then to come in and close that eyelid coloboma. That you can only do surgery so many times, right?
That's fantastic application there.
Yeah.
To be able to protect the eye like that.
Yeah. Go ahead. And we notch around that where the lid is actually stuck to the globe there. You can actually create the lens that goes around that area there. Here's an example of what I call crazy lumpy eyes, and there's a lot of crazy lumpy eyes out there. And this particular patient has a corneal neurotinization, right? So they took a nerve from her leg and then brought it up and put it onto her eye. But the problem is she's neurotrophic. She can't shut her eyes, so she has extreme exposure. She kept getting infections. Her cornea was breaking down. It was a terrible situation for her. And so by taking this impression, you can really see those nerves coming around the cornea there. They were very, very high. I mean, we are talking almost 2 millimeters in elevation here. But we created a lens, and you can see the lens on the right-hand side there. It just literally goes up and over all of those nerves. And this was done in one lens, right? One lens. It didn't require any modification to this eye at all. And she's been wearing these lenses now for a couple of years actually, and her scar on her cornea has regressed. We actually ended up doing another impression after about maybe 6 to 9 months of lens wear because everything calmed down so much. You can see how angry her eye was when we first started. Everything just calmed down to the point where her elevation changed, and we had to do a new lens because she improved so dramatically. You can see that's an example of a non-round lens.
Are you concerned about that pigmentation on the lower lid there?
Yeah, that's what no, that's actually caused by surgery.
Oh, that was a surgical thing. Got it.
That's a surgical pigmentation, yeah, but we are watching it. Of course, she's followed very closely with my team, my cornea team, my oculoplastics team. We're all a big team at my hospital.
Sure.
Yep. Okay. Right. Here's an example of some serious diseases, and we all see these patients that are. This patient has rheumatoid arthritis and a corneal melt, and you can see in the second photo there where if you've got a lens on somebody's eye and you see that, or you see their pupil peaked, do not take their lens off of their eye because it's probably tamponading and holding the contents of their eye in. I saw this patient. We ended up taking him back to surgery. He got this big scleral graft. I did the impression right over what you're seeing there, and then I dispensed the lens, and so that is after dispensing the lens, and he's now had this lens for about a year and has maintained his eyeball in his head. We are all very happy with that. But other examples, Stevens-Johnson syndrome, graft versus host disease, lichen planus, these are very rare things, and you really want to be able to manage these patients, and you either need to send them to somebody who manages them, or if you have the right technology, you have the data-driven design technologies in your practice, you can manage these or co-manage them with their other doctors, their rheumatologists and their other doctors as well. But you don't, in some of these eyes like this, you do not have the luxury of tinkering with the design. Like, you have to get this design right, because if you get rubbing on these eyes, they could lose the eye, literally lose the eye, right? And so that's where these data-driven designs are at such a high level that you can feel confident in dispensing the lens and knowing it's not going to rub any key area on the eye. Right. Here's an example of a patient. Again, this is a patient with rheumatoid arthritis who has a persistent epithelial defect that had been there at this point for well over 6 months, and the eye was just breaking down. They could not keep it epithelialized, and even with the advent of Oxervate, a lot of these eyes, they will regenerate, but then they'll just drop right off and become neurotrophic again. And so with this particular patient, I can take the impressions are so safe on the eye that we took the impression right over this epithelial defect. We dispensed the lens. By the end of the week, that epithelial defect had actually healed in, and you can see even a year later that eye is white and quiet and happy just from that protection.
Oh, impressive, very nice.
Mm-hmm. These patients have a lot going on in their lives. The plastic needs to be the least of thing that you're dealing with,
Yes, you're right.
So so the other thing with data-driven designs is when you're dealing with plastic that's in the eye and you have a plastic, squishy tissue plastic sandwich, the squishy tissue often does not win, right? So when you drop a contact lens on these eyes, a tube comes in and it arcs, right? And so there's a high point to that tube. And often that high point is going to be really close to the edge of that lens. And that's where your rub point is going to be. And you can erode that tube. Tube erosions are bad. They're also very dangerous, right? Because that person could get endophthalmitis. You could lose the eye for that patient. This is a very bad consequence of fitting eyes with hardware. Even a scleral sutured or a scleral sutured IOL will have knots buried right under that sclera. And if you don't know where they are, you will have a plastic, squishy tissue, plastic sandwich, and you will erode the knot out of the patient's eye, sending them back to surgery. So with data-driven designs, especially specifically, impression-based designs, you know exactly where that dot or that knot is, and you will have a bump in the lens that's right over that knot, so you will not squish that down. Right? And so what we do in the software is when there is a tube, we actually can increase focally the elevation. We add about 400 microns automatically right over a tube. And by adding that 400 microns, what happens is the conjunctiva is going to migrate in underneath that, and the conjunctiva is going to thicken, but you will have plastic conjunctiva, but no pressure on the plastic that's below it. So you don't end up with a compression of plastic, squishy tissue plastic, and you'll be confident in avoiding those erosions over the tube. Again, you don't have the pleasure of time of putting a lens on and go, ooh, it eroded, my bad, right? You can't make those things happen. You have to feel confident. Go ahead.
I like this one here. This is targeted conjunctival prolapse to fix the problem. I like that.
It really is. It really is. And you can watch it. You can watch it migrate. It's not prolapsing onto the cornea. It's kind of thickening up
right over the tube. That's beautiful.
Yeah, and well, actually, I can actually teach a whole separate lecture, but I can teach people how to measure it and watch it over time to make sure that you're not getting thinning of any of the tissue in those areas.
Very nice. Yeah.
Yeah, and I've had people wearing these designs now for 10 years, right? So I've watched a lot of these tubes over time, but I've made mistakes. I know what to avoid. Okay, so why data-driven designs? Basically, it comes down to, go ahead and just keep clicking. It comes down to you're fitting the actual ocular shape and not guessing, right? So it's going to speed up, it's going to create the experience that patients are looking for. When you think about the refractive surgery world, patients expect to see right away, or they expect to have that experience of good vision right away. When you go into cataract surgeries, patients expect to have these incredible outcomes right out of surgeries, right? And the same thing is happening with contact lenses now at this point as well. Our patients, no matter how complex they are, even those crazy eyes that we were looking at before, people expect it to just work. They expect you to know how to manipulate the plastic. What they really want you to spend your time on is getting to know who they are, and they want to know that you know that golfing is really important, right? Or they want you to know that they're going to be doing a lot of time on the computer and that vision is really important. That's what I think patients want.
Sure, absolutely.
Go ahead and click one more.
They come in, and just like my menu is short, their menu is short. They came in, fix me. They're not concerned with all the hurdles you have to jump through. All they want is just fix me so I can go back and live my life, whether it's playing golf or the case may be. And why data-driven designs? Because we're really creating plastic to fit the eye rather than the other way around. When you're doing diagnostic fitting, you're basically taking an eye and trying to fit it into some plastic that's already pre-designed. And this is just a much, much better process.
I tell patients it's like a couture suit, right?
That's exactly it.
Yeah. But like you said, you were able to get those patients in and out of your practice, right? Because you had that data, right? So I think our colleagues really need to think about how much time are people spending, not just in their chair time, but in the callbacks, right? What is it worth to you to put a lens on the patient and have the first lens go, oh my gosh, doctor, this feels great, I can see, as opposed to going, well, we're going to try again. And because you do that so many times, it breaks their confidence,
That's correct. You kind of lose the trust bond that you would normally be able to form when you just get a lens on and said, wow, this is really good. And again, you take the lady who traveled in with the son that came to see me. I mean, she was traumatized. She didn't. When I said to her, let me put you into a lens, you're here. She said, I don't think so. And I said, no, let's. And what she did was, that's the reason why we ran out of time with her. She waited to see how her son did first before she said, oh yeah, he did pretty well. Maybe he can help me out. And then I got the first pair of lenses on her, and not only wasn't she traumatized, she actually had good vision, and she said, "Wow, these are really comfortable. This isn't like what I had before." So that earns that trust rather than breaking the trust that you're trying to get. You're absolutely right.
Right. Yeah, and the patients look at you and they say, "Is this going to work? Is this going to work? Is this going to be okay?" And I find with these data-driven designs, I can say, "Yes, you're going to be fine. You're going to be absolutely fine."
Yep.
It's all going to work. All right. And I think that clicks one more time. I think that really
Yeah.
brings us back to our last point is data-driven designs take the focus off the plastic and put it on the patient, right? It's paying attention. These data-driven designs, they pay attention to details. So you don't have to pay attention to those details as much. You can pay attention to the patient.
That sums it up very nicely.
Uh,
Great
So,
job,
Bill,
guys. So, hey,
all right.
I know we're running a little bit long, but I've got an important question for both of you. I made a transition myself to data-driven designs about 3 years ago, and I made the mistake of thinking that these data-driven designs were only for the train wrecks, the ones that I
Mm,
yeah,
failed
yeah.
on. And I made that mistake for about 2 years, thinking that I'm just going to save this for the ones that are failing in my traditional lens designs. Since then, I've come across multiple practitioners that I've learned from, and some of which are doing 100% data-driven designs, even on a dry eye patient or a normal cornea and things like that. So, do you want to comment? And I love seeing these complicated cases, but can you comment a little bit on the quote-unquote normal corneas that you fit with scleral lenses, and the fact that you still use data-driven designs for those eyes?
yeah, I do 100% data-driven design, and mostly it's because you're going to spend the money one way or the other, right? You're going to spend the money in your chair time, patient time out of work, something. The money's going to be spent one way or the other. Data-driven designs really aren't more expensive than diagnostic fitting, because you're saving money in your chair and patient happiness and everything. And so I have switched over. Mostly because I'm happier, my patients are happier, my staff is happier. They're not fielding the phone calls, we're not doing the back end work, we're not doing the returns. It's so much faster. Everybody from beginning to end is happier.
And I myself, Bill, in answer to your question, I started back in 2000 with this, and interestingly enough, kind of like you at the beginning, I kind of said, well, yeah, the more complicated one I'll use this for, and then the normal stuff I'll just continue fitting normal lenses. And again, I'm not just talking about sclerals, but even corneal GP lenses at that time. And
Hmm.
what I came to realize very rapidly, why am I fitting an inferior product for the normal eyes?
Hmm.
It's not even close to performing nearly as well as I can do from these data-driven designs. And so it took me probably all of about 3 or 4 months, and I just abandoned all of the diagnostic fitting and just dove right into all the empirical fitting to get good data, design up a lens, get the patient successful, and ultimately successful in a better lens. It's
Hmm.
not just that it was faster; they're actually got a better product at the end point as well. So yes, I would agree with the path that you traveled, Bill, because
Hmm.
it's the exact same thing that I did at the beginning as well.
Yeah,
Yeah,
you know,
it was an
oh,
expensive lesson.
well, you have to think about what type of practice you want to build and who do you want to attract to come to your practice, right? And people don't come to me because they want meh,
Mhm.
right?
That's right.
They want it to work and they want to move on with their life, and they want me to be the least important person in their world.
Well, I don't know the answer to this, but I'm pretty sure it's the same one that I get all the time. How many times, Chris, has the patient looked you in the eye and said, "You're my last hope"? Because they've already gone through so many lens
Yeah.
designs that didn't work, and they're relying on you to now get them successful.
Yeah, and whether they say it out loud or whether I feel it. So sometimes you feel it.
Yeah.
Yeah.
Sometimes there's this underlying thing that patients bring to our package or practices, and it's hope. but it's also despair. And
Right.
we have the ability to make our patients crazy. We have the ability to dash their dreams. And it is my responsibility, I feel it is my responsibility, and I feel this very deeply, to always be offering them and to know what's out there and how I can make their experience better.
100% agree. That's the
Hmm.
exact same way I think about it as well.
One
Hmm.
more clinical observation I want to get you both to comment on, and Chris, you kind of touched on it briefly in the beginning of the talk. One of the first things I noticed as I entered into the data-driven world is my fits were so much better that things like midday fogging almost came off my plate, and I didn't have to deal with that
Hmm.
anymore. But the new thing that came on my plate, and it wasn't common, but it did happen occasionally, was it fits so darn good that now fenestrations were necessary. So can you just comment a little bit about, if you do fenestrations, where do you place them, especially in a highly irregular cornea, and how often do you do that? And Ken, same
Bill,
question to you.
Bill, I have so many questions about what your fits looked like before you did data-driven designs. But anyway.
My patients were remarkably happy with really bad fits.
So, but anyways, with I don't find that fenestrations are necessary all the time. So with the way
Mhm.
I design lenses and the way I do them, it's a tangential landing 360 degrees. So the lenses aren't tight. They don't transfer tears, but they're not tight. So like when you take them off, there's no, like if you take a lens off the eye and it's going when you take it off, either you're taking it off completely wrong or that lens is way too tight. But I do am using more and more fenestrations for my graft patients. And I'm always beginning to
Mhm.
wonder if we just should fenestrate our graft patients. And I put them in the mid, I'm a fit big person.
Mhm.
And I don't know if it's really necessary if you're fitting a lot smaller, but I'm a fit big person because I fit all these crazy eyes. But I put them at 10 and 2 to start. And what I find is about a 2 millimeter, 2 to 3 millimeter fenestration at 10 and 2 will release a lot of the negative pressure that we get underneath these lenses. And I'm not 100% sure if this is all an oxygen thing. I think on these graphs, suction compromises endothelial function. And when we release it so there's no suction during wear, I have patients that have been wearing fenestrations for 5 or 6 years without any edema, whereas prior to that, they'd had edema. And so I think fenestrations are quite helpful for that. What about you, Ken?
I agree with you that number one, I don't think it's about oxygen. I think the
Hmm.
suction forces. Yeah, one of the things that newer scleral lens fitters always sort of kind of wrap onto is, oh, well, it's vaulting the cornea, so it doesn't do anything to the cornea. Uh-uh. There's plenty of
Hmm.
forces that are underneath these lenses that have impact on the cornea. And I agree 100% with you that oxygen is certainly one of the things, but I do think that you have, the suction forces as well as compressive forces. Again, don't forget that a sealed lens has a sealed system underneath it, and as the lens settles throughout the day, liquid is not compressible. And so it is going to compress all of that into the cornea. So you are having an impact on the cornea. It may not be like a corneal GP with plastic on a cornea, but you still have an interaction between the lens and the surface of the eye.
Hmm.
I personally I fenestrate just a very few. It tends also to be kind of centered around graft patients. I agree with
Hmm.
you on that as well. Uh, on the other ones, I think that when you get these data-driven designs, unlike Bill, who seems to be getting them to suck on really good, when you have this sort of tangential landing over a fairly
Right?
large area, it really does come off very easily. It
Hmm.
really does. You don't have that sort of like that pop sound like you're talking about. And so I agree, probably getting the flange of the lens to be much more tangential evenly all the way around, which is impossible with any diagnostic fitting. You just can't do that because it's just too irregular. But with these types of designs and you get these sort of free-form flowing flanges, I think you really get a much more even bearing over the entire surface, and that avoids a lot of
Hmm.
that problem.
Yeah, I
So I
think
said,
with the data-driven designs, the suction is less of a problem. I think the limbal hyperemia is less of a problem, and midday fogging is less of a problem. Almost to the point when you see it, it will feel unusual to you. Like you'll be like, oh, gosh, what's going on here? As opposed to the regular seeing it very regularly that you do with
Right,
and
I
that's
agree.
exactly true from
Those
my
are the
experience.
unusual. Those are the
it's
unusual
unusual.
type of things. They're not regular at all.
So I said
Hmm.
that was the last question. I have one more question that came in. It's a really good question. And it's how do you deal with the irregular cornea optics? Do you, when you order your first lens, if you don't have a trial lens and a base curve and a power to start with, do you deal with your first lens as a fit lens and then do an over refraction? And this is for both Ken and Chris. Or do you do some kind of optical calculation, even though you don't have a spectacle RX because the cornea is so irregular? How do you deal with the optics? Is it a two-step process, or is there some trick that you guys do without putting any lens on the eye to do this calculation?
I'll go first.
Yeah,
So,
go.
so, so, so when I started fitting from the scleroprophylometry back in 18, and all of a sudden these first fits were really good. I mean, wow! It's like I was amazed how much, like I was 95 to 100% there on the first lens fit. I briefly had this brush with maybe I should get those diagnostic lenses out so I can get some power readings and then I can get more accurate power readings. And what it turned down to is, what it turned into is I said, well, I don't really want to waste the patient's time. I don't want to waste chair time on that. You know what? I'll just continue to do what I'm doing, assuming that if I just have to make a power change, I'll order a second lens. And if I don't have to make a power change, great, we're fantastic. So as far as tricks up front without doing a diagnostic fitting with a base curve and a trial lens power and all of that, what I will do is everything at my disposal. So if they came in with a lens, I'll neutral, a GP, I'll measure base curve, powers on that lens, and I will just put that to one side. I'll try and refract them. How close is that to what the parameters were on that GP lens that I just took off there, from that they come in with? One of the nice things is I get on the Pentacam aberrometry some more refractive data. So I might take all of these things and try and come up with some best guess as to what the optics are supposed to be for that first lens, with the idea that, I'm probably still going to tweak something. Even if it's a minor edge thing or something like that, I'm still going to tweak that and I'll just take care of the power at that time once I have a good fitting lens. Because one of the things that I found, I don't know if you found this, Chris, but one of the things that I found is that you remember, like, historically, that you have an irregular cornea, so put any GP on there so you can get some potential for vision. Well, what I found is that's actually the least amount of potential for vision you get, because if the lens doesn't fit well, even if it stays on long enough for you to do an over refraction, it generally is still wrong. Because once you actually get the lens to fit properly, it's no longer tilting. It's really
That was the
sitting.
Yeah.
You're right. It's sitting properly.
That's exactly the point I was going to make. That was exactly the point.
Right.
So even if you get over refractive data, you're almost always going to have a second lens for power, because when you get a lens, a data-driven lens isn't going to go, and
Correct.
now you're looking through the optical center and you're not getting tilt and you're not getting drop and you don't get that weird coma, then da 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 da, like all this stuff, right? And you
Absolutely.
often will get a different power. So I try to get in the ballpark. I may throw a lens on to just get a quick refraction, and by me I mean my staff, to get us into the right ballpark. But I I don't say this is going to be your end all be all power, right? Because you really can nail down. And with data driven designs, putting torics on the front surface is not an issue. It is not hard to
No.
do. And you're not trying to like weirdly do oblique cross cylinder stuff. Like you don't have to do any of that. Like
Right.
you just tell them what the power is and it literally just gets put on the lens. And
That,
because these lenses sit so securely. So yeah, I mean, you want to get in a close range, but I mean,
yeah,
if somebody's a high myope or a hyperope or something like that.
that's exactly it. I'll try and get in the ballpark, but if you put a trial lens on and like you said, it's tilting or it's decentering or whatever, that's not going to be an accurate refraction anyway. And so I'm probably gonna still have to fine tune it, which is why I really didn't break out the diagnostics. I'll just take my best guess for that first lens and move on, with getting the lens on. So I have a good fitting lens, and now it's trustworthy that I can get an overfraction that's proper.
Yeah, so I have a set of just Plano lenses that there are a whole bunch of them, right? So that my staff will, after we grab, I go in and I talk to the patient, right? Who are you? Why are you here? What are you going to expect? What is your care map? What is your road map? How many visits are we going to expect here? Is this all going to work into your life, right? Once we've established we're going to do this, I then uh, uh, I leave. I have a staff that comes in, takes the impressions, goes, puts my Plano trial lens on, does an over refraction. Patient comes out, we all hug, and they move on. And I see them back for their follow up, and I go through the same thing with them again. How are you doing? What's going on in your life, right? And I drill in on. That's when I drill in on that refraction at that point.
See, I don't have that
Makes a lot of
staff to
sense. And so
delegate that
it's
to.
patient
Life dreams, hopes and
expectations.
dreams.
Well, Chris and Ken, I can't thank you guys enough for sharing your expertise with all of us. As always, you always learn so much from these presentations. Thank you so much for spending the time tonight, and I look forward to the next time we do one of these again. Have a great evening.
Thank
You all as
you.
well. Thanks a lot. Bye-bye now.